All right. So we do have three incredible experts here today to share their knowledge in the area of weight loss and weight management. And so often I think weight loss is the first thing that we think of as employers. We want to help our employees lose weight. And sometimes we might do that with the Biggest Loser weight loss challenge or a SEPS competition. But the question is, what happens when those things aren't enough? So today we're going to dig deeper into the strategies behind successful long-term weight loss and learn methods for supporting employees from a psychological perspective all the way through the clinical continuum of care when it comes to weight loss and weight management. So during the presentation, please feel free to take advantage of the chat. We'll have time at the end for questions. We've reserved about 10 minutes at the end, so please make sure to enter all of your questions in there. And this session is also recorded so that you can watch it at a later time as well. So to jumpstart, we have three great experts with a very long list of accomplishments and accolades. So I'll give just very brief bios so that you have an understanding of their background, starting with Dr. Stephanie Schwartz. She's a licensed clinical psychologist with specialized training in health psychology. She has experience working with a variety of medical and psychiatric populations, including anxiety disorders, eating disorders, bariatric surgery, infertility, oncology, and hospice palliative care. At Baptist Behavioral Health, she completes psychological evaluations for patients who are undergoing bariatric surgery, and she provides follow-up therapy to those patients both before and after their surgery. She also has a background in leadership, program development, research, and teaching medical school students. We also have Dr. Pamela Rama. She's a non-invasive preventive cardiologist. She believes in education and awareness and that they are key to prevention. She shares her expertise frequently by giving presentations on risk factors like high blood pressure, diabetes, and obesity. She focuses on early treatment for women especially because she's seen so many women at home who have chest pain and never even consider that they may be having a heart attack. In addition to her clinical practice, she's the current chief of staff and medical director of cardiopulmonary rehabilitation for the Baptist Beaches Hospital. Her areas of expertise include, but are not limited to, heart disease, research medicine, diabetes, high cholesterol, and non-invasive cardiac testing. And finally, we have Dr. Craig Morgenthau. He's a board certified general surgeon who specializes in minimally invasive surgery. He utilizes techniques with laparoscopic and robotic surgery that are less invasive, which provides patients benefits, including reducing their pain, fewer complications, and faster recovery time. He enjoys making a connection with his patients and treats them as if they are his own family. He has written numerous publications and is very active in the organizations of the American College of Surgeons, the Society of American Gastrointestinal Endoscopic Surgeons, and the American Society for Metabolic and Bariatric Surgery. So we've got a whole host of knowledge here. With that, let's jump right into it. Again, feel free to put all of your questions in the chat and we'll address them at the end of the presentation. So I'll turn it over to you, Dr. Schwartz.
Okay, can everyone see that? Okay, can you see that?
Yes.
Okay, doesn't want to attack. All right. So what I'm going to do today is I'm going to talk about behavioral weight management, which is different strategies that we can all implement in how to change whether it's exercise, eating behaviors. And although I'm going to present some contributing factors and data related to, now in the time of COVID-19, the strategies I'm going to talk about are strategies that, regardless, are things that people can apply. All right. So, okay. Now, just like the freshman 15, we're hearing about the COVID-19. Recently, the American Psychological Association, and actually this just recently came out in February 2021, did a study about stress in America during this pandemic, and they polled about 3,000 US adults. And what they found was 61% had undesired weight changes. And that could mean either weight loss or weight gain. 42% of those were weight gain. And in addition to that, we are also seeing engagement in unhealthy coping mechanisms. But part of this undesired weight change, and we'll talk about the factors, are we're also seeing increased rates of depression and anxiety. And I didn't include these statistics in here, but they are very significant. And working in behavioral health, we are just seeing that in general by the significant number of calls and referrals that we are getting. And even the patients we have been seeing, the increase and escalation in their symptoms. So this was already something that was, out there, and it's really been increased now because of a number of factors that we'll talk about. So in terms of the weight gains that we're seeing, this is also related to engagement in unhealthy coping mechanisms. So this is a big contributing factor. And this is in response to stress, depression, anxiety that people are experiencing, turning to overeating, emotional eating. Increased alcohol consumption has been a big one, and we're also seeing increased rates of substance abuse. And how does that relate to weight gain? Well, additional calories, of course, is a big one. And also changes in sleep patterns is something that's a contributing factor too. We all know that if our baseline, we're not taking care of those critical things, it sets us up for increased stress and then increased negative responses to that. Negative self-talk, and I'll talk more about that because cognitive behavioral therapy is a big part of weight management. And that's when it really perpetuates the negative things that you're saying to yourself, really then perpetuate the cycle of, I feel bad about myself. How did I get to this point? Then you feel bad, you turn to eating, and then you feel bad again, and the cycle perpetuates itself. And prolonged stress. Our body is not set up for this prolonged stress. Fight or flight is usually a car pulls in front of us, our body reacts. Cortisol, hormones, it's not set up for this constant refiring. So really what we're seeing now is a lot of symptoms, medical and mental health challenges in the time of COVID. Okay. So some COVID specific contributing factors, change in routine is a big one. People were quickly forced to make a number of changes. And it's now, and we'll talk about strategies, people, if they haven't already, coming up with what is that new routine for them. And now a new stressor that's coming up is now that people have maybe after a year gotten into a routine of working remotely, they're gradually having to now go back to the office, which people have gotten comfortable, dogs around them, everything they need to do. So that's another then factor that's going to contribute to stress. Being sedentary. We often get up, and I know this isn't for everyone because where a lot of people are going back to the office, but the majority of people have been staying at home, or at least over the last year. And that's what we're focusing on in terms of the statistics, the weight gain that we've seen over the last year. So we sit up and we wake up and we go right to sitting at our desks. And then we tend to stay there even longer. So many people, rather than having that drive time, are sitting right at their computer and extending their work hours. So also not actually having that social support, which help with stress. Many people on their way to work, listening to music, talking to friends, was their decompressor, stress relief, and it's not there. Attire, this may sound odd, but many of us, waist down in our sweatpants, pajama pants, and as we gain weight, we don't realize it as much until we then have to go back to work and put on our regular work pants. So that awareness also, or lack of awareness because of that. Isolation, for many, that's also going to contribute to depressed mood, anxiety, and those then engagement in activities that we have talked about that negatively impact weight. Having easy access to food, for some of us, our home was not set up to work from home. So our office may be our kitchen island, staring at the refrigerator all day. So having that easy access to food, also a contributor. Additional roles people are taking on, so you're working, now you're having to homeschool, you have others in the home that are also working. And then other factors that, COVID specific, like reluctance to go to the gym, understandable, or when gyms are closed. So when I meet with patients, many of them are, I was doing well with exercise and then COVID happened, so I stopped. So it's one of the strategies we'll talk about is, okay, there's other ways to exercise just because maybe you're not comfortable going to the gym. And that goes to changing the routine and coming up with what is that new routine for you. And again, this may sound odd too, but grocery shopping behaviors, people are ordering online. It's easier to click, 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 click. You're also, when you maybe do go to the grocery store, you're going to buy more in like mass quantity because you don't want to keep going if you have concerns about COVID. And sometimes that results in making poor choices or having more of those trigger foods in the home. So those are just some, but not all of the contributing factors. Okay. And with all of this, with the increased weight gain and, as we talked about, and actually one thing I, didn't share was of those 42% that gained weight, there was an average of 29 pounds, but 10% actually gained more than 50 pounds. So even patients I'm seeing, it's not just, we're not talking about I gained 5 pounds. I'm meeting with people who is 60 pounds, 100 pounds. So this is significant. And this is where it'll also go into the talks that Dr. Rama and Dr. Morgenthau are going to give, because the secondary pandemic that we're talking about is, there was already high rates of obesity, in our country. And this is now increased exponentially. And what that is then doing is leading to another concern, a secondary pandemic of increased comorbid medical conditions, hypertension, diabetes. We know that obesity and then the associated risk factors increase susceptibility to COVID. And also with obesity, as someone gains more and more weight, even if maybe they even have the motivation or used to engage in exercise, it becomes more difficult, shortness of breath, more uncomfortable. And for some people, the weight gain, they're embarrassed about it. So they're going to avoid maybe activities they used to do, walking with a friend, going to the gym. And all these things, that again then perpetuates the cycle. Addictive behaviors, and as we're seeing, people turning more and more to substances, to smoking, to these unhealthy behaviors that are becoming ongoing habits and increasing and becoming reliant upon. So another wave or a pandemic of that. And we all experience feeling down, feeling sad, a little worried, but we're now seeing these increased levels of depression, anxiety, even to the extreme of whether it's, suicide or depression, anxiety because of people being in their homes and maybe being in a, domestic violence situation. So this is another pandemic of that increased depression, anxiety for people who maybe didn't experience that at all, but then people who had that, and now it's increased even further. So this is a concern in terms of physical and mental health impacts that are coming from this. All right. And so this slide, I'll spend a little bit more time on, and this is where, regardless of COVID or not, and this is my focus in what I do as a behavioral health psychologist, cognitive behavioral therapy, really focused on the thoughts and behavior changes. And a lot of these may seem like, okay, well, this is obvious. A lot of people I talk to, they can teach a class on nutrition, but it's the implementation part that's the hard part, and often becomes overwhelming. And so that's what we'll talk about, some of these changes that you can do. Getting into a new schedule or routine. Utilize things like your alarm on your phone, your Outlook calendar. So, jumping down to setting a goal, for example, if you are tied to your computer all day, you have not been even getting up to exercise, let's say go outside at all. Setting a very small, realistic, quantifiable goal. There's a difference between saying, I'm going to start working out this week versus, Okay, I'm going to look at Wednesdays a day. It's likely to make for me to exercise. 8:30 may be a day. 8:30 in the morning may be a time it works. I haven't exercised in a year. I'm going to start with 10 minutes once this week. Okay, and then to remind yourself, putting an alarm on your calendar, putting it on your Outlook calendar as a reminder, setting up that new schedule and routine, and even setting that as a goal. This week, I'm going to look at my calendar and give myself the look at where I can implement these things. Too often, we set ourselves up like, okay, I'm going to lose, or I'm going to lose weight. I'm going to lose weight, but not quantifying those goals. So that is really actually one of the most important things in terms of goal setting. Implementing reminders, as I said. Awareness is really a key component because we can't change behaviors unless we know what those things are that we need to change or the triggers. So utilizing an app, for example, like My Fitness Pal, looking at what's going on in terms of what I'm eating, when I'm eating. And once you identify what those triggers are, then you can implement what your goals are and not overwhelm yourself. Make a list of those. This week, I'm gonna identify 1 or 2 goals, making them small, realistic, and giving yourself credit. Small steps or big steps. If you haven't exercised in a year, you used to work out 5 days a week, and look at it as, well, what's the point in getting on the bike for 10 minutes? That I'm not going to burn calories. It's looking at behavioral change, and those small steps are big steps. Same thing, even goals with undoing. There's adding healthy behaviors and undoing unhealthy behaviors. If your goal is to decrease, alcohol use, instead of every day this week where I have a drink to relax, I'm going to go to every other night, and just decreasing it and making it quantifiable and being solution focused. Looking forward, not back. It's not helpful to be like, well, this is what I used to do. I used to do this, and because that's going to actually perpetuate depressed mood. So looking now at, okay, this is where the situation is. What can I do about it? And changing your self-talk, not being mean to yourself about it. So catching yourself if you're seeing those negative words, to yourself about it, calling yourself fat, calling yourself lazy, asking yourself if you're going to engage in boredom eating, for example, you're going to the fridge. Why am I going to the fridge? Am I bored? Is it because I'm stressed? If it's for one of those reasons, what else can I do? For some people who have a history of emotional eating, when I ask them what else can they do, they're like, I don't know. So asking what worked for you in the past, coming up with those other list of strategies for yourself, all those alternative healthy ways of coping. Social support and accountability, it really helps individuals, and your family members may be having the same struggles. So saying, as a family, we're going to start going for walks. Mental health support, EAP, and this is where it comes to, I know a number of you, really your heads of HR, recognizing that it does reach a point where people need that additional assistance. Even at Baptist, we've now even increased the number of EAP visits we give to staff because to have that support, and putting it out there, because you all know many employees do not take advantage of that service. And lastly, things that you can do to increase employee engagement, whether it's contests or things like track your steps. So let's look at that, whether it's putting pedometer on, because we don't have even those built-in activities when we used to go to the office, park our car, go to and walk from the parking lot to our work. So any of those things that you can think of that are little challenges for people. Okay, again, not exhaustive list, but just some strategies. And if it's helpful, we can put, because I know, you're all mostly heads of HR, and as you want to trickle this information down to your staff, so we can certainly put a list of these things together as a handout. So I'm going to pass it over now to Dr. Rama, Dr. Morgenthau. We're going to talk about when patients need, or individuals need, that additional level of medical support in addition to these behavioral strategies. So I'm going to stop sharing my screen. Okay. You all good? I'm going to pass it on to Dr. Morgenthau now. Just, I think you need to unmute.
Hi, am I supposed to be next? Do you see my
Oh,
screen?
I'm sorry, Dr.
Yeah,
Morgenthau.
yeah.
Dr. Rama's next. Yeah, sorry.
Yeah. Can you see my screen? I just wanted to know if I was able to share it. Talk about
We
stress.
cannot.
Zoom meetings are stressful. So let me
Dr.
see how I
Rama,
can do
I
this.
can pull your
Yes.
slides up.
Okay, please. I think I can. Do you see it now?
Yep, you'll just have to tell me when to move forward. Do you see
Oh,
it?
okay. Okay. So because I have my screens up. Do you see my screen?
Yes.
Okay, very good. So we're going to talk about obesity and how this has become epidemic here in the United States. And basically, obesity is an accumulation of excessive fat, accumulation and storage of excessive fat. And the way that we measure fat is through the BMI, the body mass index. And the reason why we use this is not the most accurate, but it is so easily reproducible. And this is the one that's commonly used for when we have clinical trials. So the BMI is basically your weight in kilograms over your height in meters squared. And this is the classification. If you have a BMI of less than 18, then you are considered underweight. The magic number is staying between 18.5 and 24.9, which is the normal weight. You're overweight if you're between 25 and 29.9. Obese when you go over 30, and morbidly obese if you go over 35. So when you look at the statistics in the 1960s, so this is the percentage of US adults classified as obese in health surveys, and this is from 1963 to 2012. And so you could see that in the 1950s, 1960s, there were around 10% of males and 15% of females were considered obese. And then something happened in the 1980s where you have an exponential increase in the number of obese patients in the United States. And so why did this happen? So, when I ask this, when I lecture in front of people, their number one answer is always because of McDonald's. Well, it's not because of McDonald's. And the reason why people become obese is because in the 1980s, the Congress decided to mandate that we are going to fight fat, and all the fats were removed from our foods. And so you had a low-fat Twinkies that had an incredible amount of sugar. So with this rise in obesity is really a rise in the sugar intake among patients. So next slide, please. So I'm going to show you a series of slides that it's kind of scary, okay? So this is the obesity trends in the United States by year. So this is 1995. And you have a color map where the dark blue are states where 10 to 14% of the patients are obese, and the light periwinkle blue where less than 10% of the population is obese. So let's move on quickly to that. This is 1986. This is 1988, 1989, 1992. So when you get to 1992, you're going to see a new color map because there are states, particularly in the Southern Belt, where we're in around 15 to 19%. So for the first time, we're seeing states with obesity rates up to 15 to 19% of the population. So let's move on to 1993, 94, 95, 96, again in 97. Again, a new color map where 20%, over 20% of the population is obese. This is 1998, 1999, 2000, 2001. A new color map again appears in 2001 where over 25% of the population in Mississippi is considered obese or overweight. This is 2002, 2003, 2004, 2005. There are only a few healthy states. Healthy meaning they have a population of around 15 to 19% of obesity. And again, in 2007, a new color map looking at 30% of the population being obese. So I don't know about you, but this is a scary map, right? So we have completely eliminated the old color map with less obesity and replaced it with around half the country having more than 25% of their population being obese. So what is the scope of the problem? Next slide, please. So around 69%, next slide, please. So around 69% of the population are either overweight or obese, and around 35% are obese. 1 in 5 children are obese, 1 in 3 adults are obese. And obese patients incur around 46% increase in inpatient costs, 27% increase in physician visits, and 80% increase spending on medications. So the total cost of obesity in healthcare is around 270 billion. And this is an old statistic. So when you look at the newer statistic, this is going to be much more. So when we looked at our statistics at Baptist Health, and we are a healthcare organization, we followed a similar trend wherein 70% of our employees or health team members were either obese or overweight. So the database from a single plan employer and employee group that you might be interested in knowing is looking at this, that employers really bear most of the cost of obesity. You have indirect cost of loss of productivity and sick leave. The obese patients are 2 times as likely to have high levels of absenteeism of more than 7 absences in 6 months. The per person claim costs for obese persons were triple those for the patients for the average member. Hospital admission rate was also increased among obese patients, around 350 hospitalizations per 1,000 hospitalizations versus 50 per 1,000 for the average population. And your cesarean section rate was 50% higher for obese mothers, double that than any normal weight mother. So next slide, please. So obesity is a multifactorial disease. So you could blame some genetics into that. In other words, if your parents are obese, there's a high likelihood that you will become obese as well. There are neurobehavioral changes, medical changes. In other words, be careful about what medications your doctors give you because they can actually promote obesity. Of course, we know hormones are also related to that. Immune system has also been attributed to that. And of course, the environment plays a heavy role on obesity as well. So this was an interesting study that I just wanted to bring up. And this was not a shabby, journal. It's in the New England Journal of Medicine when they looked at the spread of obesity in a large social network. So what they found out was there's an increased risk of an individual being obese when a person in his social network becomes obese. So if your neighbor increases weight, there's no increase of obesity in your case. But if your spouse starts gaining weight, there's a 37% chance that you will be overweight as well. When your sibling becomes obese, around 40% increase a chance of you becoming obese. But when a friend becomes obese, there's 171% increased risk in becoming obese. Now, surely, so this was 12,000 patients looking at the Framingham Heart Study. So that the chance of becoming obese is increased by 57 to 171% if your friend becomes obese. Now, surely we all know that obesity is not contagious, but it just goes to show that your activities, like when you are with somebody having lunch with a person and the person is ordering a salad, I think you're more inclined to order a salad as well, right? So shared activities are very important. Again, we spoke about how obesity is a complex and multifactorial disease. It really is an imbalance in your energy. So usually what we want is the energy that you expend should be equal to your energy intake. And there is a fine balance that keeps your weight and your fat status stable. This is an important slide because it's going to reinforce. So I'm sure that a lot of you have gone on diets, right? So if I can show of hands of how many people have gone on a diet, it's probably going to be half, if not 2/3 of the room. So you lose 150 pounds, and so if you're 100 and let's say you're 200 pounds and you lose around 10% of your weight, 20 pounds. After you lose 20 pounds, something happens because you hit the plateau, you start feeling hungry, it looks like your metabolism starts to slow down. There's actually a physiologic basis for that. So the American Medical Association recognized obesity as a disease in 2014, and that led to the payment of insurance companies paying for anti-obesity medications and therapies. So it is a disease because it has characteristic signs and symptoms. The increased fat mass is associated with comorbidities such as type 2 diabetes, cardiovascular disease, and cancer. And we know that the disease results through a perturbation of the central nervous system regulation in energy hemostasis. So as I told you earlier, your food intake and energy expenditure are balanced by a homeostatic system that maintains the stability of your body fat content over time. And this is regulated by the brain and very affected by so many other organs. So this is also, again, a very interesting study where they looked at 50 patients and they followed them for a year. And what they did was they placed these patients in a very intensive weight loss program. So a 10-week program must have been very good because a majority of them lost 30 pounds. And so they found after the program was over, they looked at these patients over time. And what did they find? A majority of the patients had regained their weight after 1 year. Okay, and this is the problem that we constantly see in ourselves and in our patients, right? And so what did they find out? The 14% weight loss, when you lose 14% of your weight, it produces changes of 8 hormones that encourage weight gain, right? So what happens is that they looked at the leptin level. Leptins are hormones that make you feel full right away. And the ghrelins are the bad hormones that make you feel hungry all the time. And what they found out was that the good, hormones that cause weight reduction is reduced, and the hormones that increase your weight, makes you feel hungry all the time, are increased. And these changes are profound and persist up to a year. So you have sustained elevations of appetite stimulating hormones and a decrease in appetite suppressing hormones with the result of hormonal changes. Then the result of these hormonal changes is weight gain. So I know it sounds, it sounds depressing, but there's help. I just wanted to go over the medication. So a lot of you take medications for various reasons. Just make your physician aware that your physician should be aware that there are medications that promotes weight gain, and there are alternative agents. And one of the things that I would like to point out is especially antihistamines. So you think if you have chronic allergies, Benadryl and Zyrtec and Allegra tend to be promoters of weight gain. So you may want to, if weight is a concern for you, you may want to switch to Claritin or Loratadine. The same thing for hormone contraceptives. The copper IUDs and oral contraceptives are less likely to make you gain weight versus the Mirena. And of course, blood pressure medication. So there are blood pressure alternatives that are weight neutral. Next slide, please. So what is the risk of being obese, right? So next slide. So we know now that obesity affects every organ in your body. So it causes sleep apnea. It can cause you to have strokes. It increases your risk for heart disease by increasing your risk for diabetes. Your cholesterol goes up, your blood pressure goes up. Asthma and pulmonary blood clots are common among obese patients as well as fatty liver and cirrhosis. The list goes on and on. Cancer, breast cancer, uterine cancer, colon cancer are increased in patients who are obese. So what we know now, next slide, please, is that modest weight loss has profound benefit. So we might not get you to a size 2, but getting 3% weight loss, you already see an improvement in your glucose. You already see an improvement in your triglycerides. When you get down to 5% weight loss, your HDL, which is your good cholesterol, goes up. Your blood pressure goes down. Your fatty liver improves, and people overall just feel better, right? The symptoms of urinary stress incontinence goes away. The measures of sexual function improves, and the quality of life overall improves. And this is just with 5% of weight loss. When you get up to 10% of the weight loss, then you really can sometimes see a reversal in your fatty liver and a reversal in your sleep apnea. So improvement in sleep apnea. Now, it's not, though, until you get to 15% of your weight loss that you actually see reduction in cardiovascular events, mortality, and remission of type 2 diabetes. This is hard to obtain. It's not impossible, but this is the levels of weight loss that you see among patients who end up with bariatric surgery. So the strategies to improve or intensify weight loss, first of all, lifestyle change is the cornerstone, as Dr. Schwartz had mentioned, right? So diet and exercise, it could probably give you 3% to 5% of weight loss. Pharmacotherapy is now available. So ever since obesity has been considered a disease, more and more insurance companies are covering anti-obesity medications, and they're pretty pretty effective. They're used as adjunctive therapy. They assist when lifestyle changes have been made and you're still needing to lose more weight, and could probably give you another 5 to 12% of weight loss over lifestyle. And then again, bariatric surgery, which Dr. Morgenthau will be speaking about, there are specific patients that would qualify for that, and I'm sure he'll go over the indications with you. So these are the type of patients. So when we see our patients, somebody who basically has a BMI between 25 and 30, really has no complications, they're not hypertensive, they're not diabetes. These are the patients who probably will do well with lifestyle modification. But if you have somebody with a BMI of greater than 27 and they already have comorbidities like, hypertension or diabetes, we will be aggressive with the lifestyle changes, but this is somebody that we would consider adding medications to. And just as a note, if you have stage 2 obesity and your BMI is over 40 or over 35 with comorbidities, the only really successful therapy in maintaining and changing your risk for death, for diabetes, is bariatric surgery. So I know that you've all been through all types of diets. And if you look at this graph, this is basically the patient's response to diet. So every response is going to be different. There are patients who are going to not lose weight or even gain weight. There are patients who lose a great amount of weight, and those that don't respond or gain weight. So the same thing as we're seeing when you look at patients on medications with diet alone, you have those patients who can you go over to the next slide, please? Yeah, so when you look at this slide, you have in every point in this graph is a patient. So you have patients who will gain weight, you have patients who have no response, and then you're going to have patients who are super responder with any type of weight loss management that you do. As far as pharmacotherapy is concerned, again, we consider it in patients with a BMI of 30, or if they have a BMI of 27 and have comorbid conditions related to obesity, particularly hypertension, diabetes, and sleep apnea. Patients should obviously attempt lifestyle change first and then discuss with your doctor the benefits of medications. There are 5 medications that's been approved. The reason I hesitated was last 2 years ago, there were 6, but they had to pull out 1 because of the increased risk of cancer. Phentermine is for short term, and we really don't recommend phentermine because, as I told you in my previous slides, that if you can't have medication just for 3 months. It has to be a continuous type of medication to really have a sustained weight loss with any of these types of medications. Phentermine, topiramate, or Casemia is the one that I use most in the practice, but there are other medications that are available. And your doctor will choose, depending on your profile, which medication is good for you. So now that obesity is considered a disease, once it's just like hypertension, once you have the blood pressure under control, it doesn't mean that we're going to stop the medications, right? So hypertensive patients most likely will need their medications lifelong. And so goes for obesity medications. So some of these patients are on these medications for a long period of time. So again, we went over the weight management intensification options, wherein diet and lifestyle will give you around 8%, plus obesity medications, you give you around 12%, and then gastric bypass, you could go up to at least 32% of weight loss with bypass. So this is as conclusion, it is a complex chronic disease of excessive fat accumulation, and it does affect your health and mortality. Treatments includes a comprehensive program. Lifestyle is the cornerstone, and then we can add pharmacotherapy or bariatric surgery depending on your BMI category. I know that was fast and quick, but I am going to now turn it over to Dr. Morgenthau.
Okay, hopefully everybody can hear me now.
We can hear you.
Thank you very
can
much,
see your
Dr.
slides.
Okay, excellent. All right. Thank you very much. And just moving on to bariatric surgery. Dr. Morgenthau, the medical director for Baptist Center for Bariatric and Reflux Surgery. And Dr. Rama spoke about body mass index. And we have a BMI calculator at baptistbariatrics.com. And so patients can see where they fall into that category. but patients that are eligible for bariatric surgery in that morbidly obese category, either a BMI over 40 or over 35 with a comorbidity like type 2 diabetes. And this is the same slide, just showing the epidemic of obesity. And on the left, that's obesity, and on the right, that's morbid obesity or BMI over 35. And this projects it out to 2030, where Mississippi, Alabama, now we're looking at over 50% obesity and morbid obesity in the range of 20 to 30%. And of course, obesity affects every part of your body. Some of the big ones: heart disease, diabetes, joint problems, sleep apnea, and cancers, of course. And with increasing weight, there's increasing severity of those comorbidities, and more of them show up. And then Dr. Schwartz touched on COVID, and I think COVID has heightened everybody's awareness of obesity as a risk factor due to the comorbidities that you have on the left there. You see that there's chronic inflammation, sleep disorders, lung disorders, and so many parts of your body are altered with the disease of obesity. And so what happens is you have increased susceptibility and severity with COVID-19. And then, as Dr. Schwartz also mentioned, by staying at home, you're at risk for worsening obesity. So this is not a good cycle. This was a study that showed that versus patients with normal weight, just being overweight, BMI 25, ventilation of 12%, and when you were obese, morbidly obese, it was 108% higher risk of being intubated and having respiratory failure. So this is Dr. Rama's slide. Behavioral modification, pharmacotherapy, bariatric surgery. You really need to have all options. I think the key is prevention, but once you get to the point of morbid obesity, bariatric surgery is the most effective treatment. And for every treatment, you need to have the lifestyle intervention. That means eating 3 small meals a day, cutting out snacks, exercising regularly. Different high-intensity behavioral counseling can increase success of those changes. But ultimately, when patients get to the point of morbid obesity, unfortunately, less than 5% of the people can lose that weight and keep it off long-term. And this is the same study that Dr. Rama talked about. So basically, that black line is your baseline. So the hunger and desire to eat, it's still elevated at over a year once you stop your diet. And the hunger hormones are still elevated, and the satiety hormones are depressed. And so, so we know diets don't work. There's a lot of medications. Dr. Rama mentioned 5 medications, but there's really no magic bullet. A lot of the medications have side effects, and it's definitely a place to start. And I think, like I said, you need all options, but sometimes that amount of weight for somebody, for example, that's morbidly obese, that's not going to impact their comorbidities. And there's a high rate of recidivism or weight regain, and then feeling like a failure when you're just not addressing the issue. We know patients can lose weight, but overcoming your biology is very, very challenging. So we start to talk about bariatric surgery. Even as far back as 1991, there was enough information, enough data to support bariatric surgery as the most effective treatment for morbid obesity. And bariatric surgery can improve or resolve most of those comorbidities that were on that previous slide. The NIH also recognized diet failures, but patients should attempt lifestyle changes before going to surgery. Of course, you're not going to gain weight and go to surgery. You need to try the other options first. And with surgery, you still need to do the lifestyle changes to have that long-term success. Surgery is not a cure by itself. So it's very important that patients understand that going in. Candidates, again, a BMI over 40 or over 35 with any associated medical problem. And as I mentioned, patients need to understand the operations, what they are going to do and what they're not going to do. They're not going to change who you are. They're not going to change the choices you make. You still have to make those lifestyle changes and make good choices. So the different options that we have available, the lap band, sleeve gastrectomy, gastric bypass, and less frequently biliary pancreatic diversion duodenal switch. How do the operations work? They all make your stomach a little bit smaller. So that's restriction, limiting the amount of food that you take in, makes you feel satisfied with less food. With the gastric bypass, we bypass some of the intestines, so you have reduced calorie absorption. The gastric bypass and sleeve, they do have digestive hormone changes that equalize some of the biologic changes that promote weight regain when you have a diet. And as I mentioned, the sleeve and the bypass have multiple mechanisms. All these operations we can do laparoscopically so that you have a faster recovery, and we'll talk more about that. The lap band, we really don't do anymore. It was considered a safest option because we're not dividing bowel, but unfortunately, we had to remove about half of them by 5 to 10 years for various reasons. And of those patients that still have the lap band in place at 5 to 10 years, about half of them have successful weight loss. So when you combine all that, you have about 25% long-term success. So as a bariatric surgery community, we felt the lap band was not the best operation to use. The sleeve gastrectomy is where we take about 80% of the stomach off. And you can see that the part of the stomach that's there in white is removed from your body, and you have that gastric tube that is the sleeve. And that's a restrictive operation. There's also hormone changes, so you have less hunger sensation. And as of 2013, this was the most common operation that was done in the United States. It's very safe. There's rare leak or infection, bleeding, or blood clots. Major complications, maybe about 1%. We typically won't do the sleeve if somebody has severe reflux or on medications for gastroesophageal reflux, but they still have breakthrough symptoms. Gastric bypass is a better option. Here's a gastric bypass. We make that small stomach pouch and we bypass some of the intestine here. So food will bypass the stomach and your digestive juices come down here, so you start to absorb your nutrients further down. So there are hormone changes. It is more surgery, and we have to divide and reconnect bowel. So there's more potential complications still. They're not very frequent. Typically, you're looking at about 2% rate of major complications that a lot of times we can avoid going back to surgery. The gastric bypass is a safe operation. With the sleeve and also with the bypass, you take vitamins for supplementation. That's important, even more so for the gastric bypass. And gastric bypass is the procedure of choice with severe reflux. And what's really amazing about the gastric bypass is that sometimes by the time they leave the hospital, their diabetes goes into remission. So there's definitely a greater impact, and there's a lot of mechanisms for that. But gastric bypass has about 85% improvement or remission with type 2 diabetes versus about 70% with the sleeve. And for that remission, it's more durable with the gastric bypass as opposed to a sleeve. So gastric bypass would be, if somebody wanted to do that and they had type 2 diabetes, that would be a stronger intervention for that. And here, I just have a slide that shows over the years how the sleeve gastrectomy has really increased in popularity because of the safety profile and because there's a high rate of weight loss success. The lap band went down, so now it's about 1%. Hopefully you can hear me over the train. And the bypass, which was about 35%, kind of came down. So now, as of 2018, which is the most current information that I have, the sleeve was the most common operation, gastric bypass next. Probably the next most common operation we do is taking out lap bands and converting to either a sleeve or a bypass. Biliary pancreatic diversion is less than 1%. It's definitely more of a bypass. It's more of it's definitely a more aggressive intervention, and it has to be for the right patient. We don't do that frequently. And this is a biliary pancreatic diversion. We essentially do a sleeve gastrectomy, and then we do a long intestinal bypass. There's a higher risk of complications, nutritional deficiencies. So patients really have to follow up closely, and we don't do this operation without making sure it's the right patient. It's less than 1% of operations. And this is one that is now kind of like a biliary pancreatic diversion, but we're doing this loop connection instead of a Roux-en-Y connection type. So it's going to be a little bit safer. This was endorsed by the American Society of Metabolic and Bariatric Surgery as of 2020, still not super common in the United States. Just to kind of summarize, the weight loss is going to be the greatest with the biliary pancreatic diversion, then the gastric bypass, then sleeve. So if somebody comes in and they're 200 pounds overweight, they'll lose about 50 to 60% of their excess weight by about a year or so after sleeve gastrectomy. So that's about 100 to 120 pounds if they're 200 pounds overweight. Gastric bypass about 120 to 140 pounds. Very low mortality rate. This is extremely uncommon. Morbidity or complications, major complications for a sleeve, I said, was about 1%. A leak is about 3 or 4 in 1,000. Hospital stay is overnight for sleeve and gastric bypass. We get about 90–95% of patients home. And we'll talk more about that in enhanced recovery. As far as off work, typically we'll say a week off of work, maybe another week light duty. No heavy lifting more than 30 pounds for the first month or so. But usually by the end of the first week, if they want to do some computer work, patients can certainly do that. And so as far as the benefits of bariatric surgery, this was a very important study that was published in Journal of American Medical Association in 2004 that showed how diabetes, hypertension can often go into remission or be substantially improved. 86% in this study that had diabetes had improved. So when you sum up that, and I'm going to go into a couple more of those studies, but basically for patients that are unsuccessful in achieving weight loss with lifestyle modification or medical treatment, and of course they've got to be morbidly obese, bariatric surgery can be life-changing and also life-saving, very important. When you look at those medical problems, this was a study that looked at patients 5 years after bariatric surgery, and the cancers went way down, diabetes went down, heart issues went way down. And to kind of sum up all of those effects on your body, when you look at the mortality rate for patients that were morbidly obese that did not have surgery, 6% of them had died by 5 years versus less than 1% that had bariatric surgery. That's including the perioperative risk of mortality. It was 0.4% or something like that. These were surgeries that were done in the late 90s, open surgery, so it's a lot safer, a much lower mortality rate. But very clearly, you see how all those health improvements add up to better survival. As far as type 2 diabetes, diabetes is highly associated with obesity. And so there's a number of randomized trials showing that bariatric surgery with medical treatment achieves better glucose control and reduction of risk factors for obesity and morbidly obese patients with type 2 diabetes versus optimal medical and lifestyle intervention alone. So a recommendation by the American Diabetes Association, as well as a number of other organizations, including the American Metabolic and Bariatric Surgery Association that I'm a member of, recommended for patients that's BMI over 40 with type 2 diabetes, they recommend bariatric surgery. And if they have a BMI 35 to 40 and their blood sugar is inadequately controlled by lifestyle and optimal medical treatment, those patients should also have bariatric surgery. Just to kind of go into some of the factors Dr. Rama pointed out, there's direct cost of obesity for insurance-related costs, and of course, the indirect costs for employers as far as absenteeism, presenteeism, disability, workers' compensation, premature mortality. That's not even including having another worker that has to be trained. This study looked at the cost of type 2 diabetes in patients versus normal weight. If they had type 2 diabetes, it was $6,000 more per year in cost. And if they were obese, that same person had about $8,000 over cost of a normal weight person without diabetes. Missed work days were 8.7 versus a normal weight patient without diabetes, lost productivity. So as those medical comorbidities and that weight adds, there's increase in cost. Absenteeism, this looked at 36 different studies with a trend towards greater sick leave among obese workers. In US studies, it was 1 to 3 extra days per year versus European studies. They had 10 extra days if they were in Europe. And all studies that followed showed reduced sick leave after intervention. There's about a 4.2 loss in productivity per year per worker based on this study. This was a Duke University study that looked at patients that were morbidly obese, and they had higher workers' comp claims, lost work days, medical claim costs, indemnity costs. And the part of the body that was most affected for workers' comp was lower extremity, wrist, hand, and back, falls and slips, lifting, and exertion. So their conclusion was that maintaining healthy weight is important for workers, but should be a high priority for employers as well. Finally, this is a study that looked at a database of 5 million beneficiaries, and they looked at the economic impact of bariatric surgery. There was a pre-op cost, and the cost of surgery for laparoscopic was $17,000, $26,000 for open. We really don't do open anymore. By 3 months, there was a cost savings, and the costs were recouped by 2 years for laparoscopic surgery. So that was their conclusion, showing that ignoring quality of life and length of stay benefits alone, as well as disability and work loss, the operation pays for itself by reducing those medical costs within 2 to 4 years. This is another similar study. So anyway, just to talk about our bariatric program, we have an interdisciplinary team, and we work with primary care physicians and Dr. Rama as well, with cardiologists. We work with plastic surgeon. We work with any specialists that we need to. We have bariatric coordinators that help the patients through the process. We have dietitians, psychologists, one of which is Dr. Schwartz. We also work with nursing, hospital staff, and administration. And so there's this metabolic and bariatric surgery accreditation and quality improvement program that we were certified by. It's a joint quality program with the American College of Surgeons and ASMBS. We've had 3 site reviews at this point. It's now over 6 years that show that we have the physical resources, human resources, standards of practice, and of course, outcomes review, which is very important. We opened up our program in 2008. We've done over 2,500 cases. We changed our name in 2020 to the Baptist Center for Bariatric and Reflux Surgery. This is a community-based program. So we do a lot of things to just make sure we have access for the community, such as not charging a program fee. Most of the other programs have a fee. We have free seminars, and with COVID, there's a webinar, baptistbariatrics.com. We have support groups that are on Zoom now. We have low interest financing options. And we, of course, know that bariatric surgery is a tool. So we want to make sure patients are ready for surgery. They have nutrition evaluation and education before surgery, psychological evaluation, physical therapy where needed. We have support groups that are mandatory. We have a pre-op class so patients know exactly what they need to do in the hospital when they go home to have the best outcome. That's important. And just to go through some of that, we also talk about make sure patients, if they haven't already made these changes in their life, that they're eating high protein, low carb, healthy fat diet, increasing fruits and vegetables, drinking only 0-calorie liquid. We try to get people off the sweeteners too. What else? We want patients after bariatric surgery, they have to slow down when they're eating. They do 1 small bite, chew thoroughly, and then 1 small bite a minute. We have them drink after meals, not with meals. You don't want to wash the food down and then eat more. You want to wait 30 to 60 minutes after the meal. And of course, we have patients be more active with more cardiovascular activity on a daily basis and weight activities twice a week. And we encourage calorie counting twice a week so you can kind of keep track, and so our dietitians can have more objective information to help patients. I mentioned this enhanced recovery after surgery. Once we did that, we went from a 2-night length of stay to a 1-night length of stay. It's probably 9. We have only a 1.6% readmission rate versus, these are some of the best programs in the country versus their 3.7 rate. So I think our program is doing pretty good. Our patients are on clear liquids while they're in the hospital. The next day when they go home, they're on full liquids for 2 weeks, and then soft food for another 2 weeks. Long term, we want patients to stay engaged with our program. This is a permanent lifestyle change. This isn't a diet, and now they have a tool to help them make those behavior changes that they need to make. They have regular follow-up in the bariatric surgeon's office with a dietitian, and they promise that they're gonna be on the support groups as well. Support groups are run by dietitians. Dietitians are available by email, and they do various things to keep the support groups interesting and keep everybody engaged. We have a Facebook online community that has the recorded support groups available and all kinds of educational videos. As far as our bariatric program, patients watch a seminar, we make sure they have coverage, they come in for a surgeon's visit, and then they do dietitian, psychologist, whatever medical testing, and then they do the physician supervised program if it's required. For Baptists, we don't require that anymore because it really doesn't make a difference in their outcome. So they just have to see their primary care once and then they come in. And then on their pre-op visit with the surgeon, we schedule surgery. So overall, it takes about 2 to 3 months, but if they have a physician supervised requirement, that could take up to 6 months. Unfortunately, with 6 months, a lot of patients drop out, which I think is pretty unfair. But anyway, so that's that. And then Dr. Rama, she kind of summarized for treatment of obesity as a chronic disease. You need all kinds of options for treatment, but lifestyle is the cornerstone, and then adding on medications. But then finally, bariatric surgery is the most effective treatment. I think prevention is the key, but once you get to the point of morbid obesity, bariatric surgery is the most effective treatment for those patients, and it can be low. Thank you very much, everybody, for having us for this talk. Thank you.
Yes, thank you so much. This is so awesome. Thank you, Dr. Schwartz, Dr. Rama, Dr. Morgenthal. This was amazing. We've received so many great questions, and in the interest of everyone's time, we'll just respond to those directly through email after the call. Attendees that are still here, if you come up with any questions that you want answered, feel free to reach out to me, and I'll be sure to connect you with Dr. Schwartz, Rama, and/or Morgenthal. So thank you so much. I hope you guys have a great rest of the day, and we'll see you again soon.
Thank you.
Thank you.